questions. Good afternoon, everyone. First off, I just want to introduce myself. My name is Rick Jewell. I am an executive assistant with the Aurora Mental Health Center, and I will be acting as the moderator for today's webinar. This happens to be our 6th webinar in this series. And however, nothing is ever perfect, so I do apologize for any glitches and/or technical difficulties should they arise. I have muted or stopped video feed for all participants in order for all to focus on the presenter, as well as to protect your individual privacy. This webinar is being recorded and will be utilized for both the Aurora Chamber of Commerce and Aurora Mental Health Center's internal and external audiences in order to continue supporting our community during this challenging time. To further protect your individual privacy, each of you have the ability to click on the 3 dots on the upper right hand of your individual screens and then rename yourself, or you can even just put ... in place of that if you wish. When we get to the question and answer section during the last 10 to 20 minutes of today's webinar, please direct all questions to me, Rick Jewell, via the chat privately. I will state the question to the presenter and all. This will help promote more privacy as to who is asking the questions. And if you so choose to keep your name visible, that is completely fine. And if you wish me to unmute your audio so that you can ask the question directly to the presenter, that is also fine. Just please state so in your private chat message that you send to me. For those kind of new to the Zoom and how it works, the chat feature is found at the bottom of your Zoom screen, and it will open up a chat feature box to the right. It automatically defaults to everyone, so feel free to change the everyone in the drop-down to say Rick Jewell, my name, in order to send those chats to me privately. You may go ahead and send questions throughout the presentation, however, they will just be held until the very end of the presentation, and we will go from there. All right, at this point in time, I would like to introduce Erin Ralston, a colleague of mine at Aurora Mental Health Center, who is going to be doing today's webinar. Welcome, Erin. Thank you so much for being here.
Yeah, thanks, Rick.
You're welcome. I'm gonna pull up your little PowerPoint for you.
Perfect, thank you. Yeah, so today we're going to talk about suicide risk and intervention in light of COVID-19 and kind of the differences that a crisis period puts on an already at-risk population. So suicide and discussion of suicide can be a difficult topic. Please don't hesitate to take a break. As we're recording this, you can also come back to it later. Make sure that you're doing self-care and the things that you need to do when you're managing difficult subjects. So on the next slide, we'll have our plan for today. We're going to be going through kind of what suicide is, just the basic stuff, then hopping into, but we're already in a crisis, on top of a crisis, right? Extra crises, not always helpful. We'll talk about what that does to our reactions. We'll talk about a way to frame interventions, and that will be a ladder frame, and then what referral and resource options we have within the Aurora community. We will save some time at the end for questions. If you do have any questions, please message them to Rick, as he mentioned. There's also, this PowerPoint will be made available at the end.
Mm-hmm.
So with suicide, it's really helpful to start with what it is that we believe and think about suicide, because it's difficult to understand, even from a science perspective, what's going on for a person if we don't understand what's going on for us as we digest that information. So being able to look at how we feel and how that reacts with our tone of voice when we're talking to someone, and maybe those foundational beliefs that we brought with us. Maybe we have a more conservative background and we have a more conservative perspective. Maybe we've lost someone to suicide, and so we have that experience. Those all play into what we believe about suicide. There are some questions that you can review if you want to dig into your own assumptions that will be in the PowerPoint at the end. So you can sit with those questions. It's something that you really want to take a few minutes to do. So as we're talking about myths, there's a lot of myths that get rolled around, and I want to just mention some of the really common ones and why they're myths. So the first is, if we talk about suicide, we will either plant that idea or increase someone's risk. And generally, if someone's thinking about suicide and we ask them, they already are. Like, it's not something that we would necessarily give an idea for. And in today's society, with the way that social media is working and all of the films and books and things that are out there, it's a common idea, especially for teenagers. If we don't talk about it, then it will go away. I think we all have experience with crises, and usually if we just pretend to ignore them, they kind of explode later on, not necessarily disappear. So important to remember that talking about them is helpful. Another myth that when someone attempts or completed suicide, it happens without warning. There can be warning. It can also happen without warning. So that one's one of those myths that's not black and white. Being attentive and connected to people can be one of the best ways to know how someone's doing. And certainly if they're in any sort of risk, that will be a buffer. We'll talk about buffers in a bit. All suicidal people are depressed. While depression is a common diagnosis for someone who has thoughts about suicide, it's not everyone. Some people may look as though they're doing quite well and be having thoughts of suicide. So it's important that we keep in mind that it can really impact anyone. I do want to make a comment about language too while we're talking about suicide. It's important that we use person-first language. Suicide is not something that's illegal or sinful in sort of science circles, right? So we say that someone died by suicide rather than committed suicide. It's not a crime, and it is how someone happened to have died. So making sure that we're using that language and being as kind as possible. Person-first language, as well as the survivor movements that have occurred, have really brought up experience and helped push forward the field in how we work with folks who are having thoughts of suicide, because they have that experience to be able to tell us what worked and what didn't for them. Okay, so Rick, move us on forward. We are in a pandemic. What does that do, right? When we look at these numbers, I want you to keep in mind that these are pre-pandemic numbers. These are rates of suicide within Colorado and what it looked like before all of this occurred, right? So Colorado as a whole was in 2016 ranked 7th. It's actually in 2018 was at 9th, so that's a little bit better. Have a significantly higher suicide rate than the nation, and that's important to keep in mind. We have seen increases overall around teens, and it's at this point 1 in 5 teens that death is by suicide. Something that we can impact, something that every single person has a role in, and having that suicide rate be really close to double the national average means that we need to step up and step in and make sure that we're talking about suicide with the people around us as it becomes normalized. So, as I mentioned very briefly, suicide is indiscriminate. It really does impact any and everyone. We do have some risk factors that would mean that someone is at a higher risk. However, none of those risk factors are guarantees, and it really comes down to the compilation of those risk factors. So we talk about chronic versus imminent risk. Chronic risk would mean that someone has a lot of risk factors. They've got all these things that have built up over time that they carry around with them. And think about it kind of like a big suitcase. The more risk factors you pile into that suitcase, the heavier it gets and the harder it gets to carry it around, right? And so that would be someone who has high chronic risk. Imminent risk is that in the moment. Do they have the ability in the moment? And when those two intersect, where they have high chronic risk and high imminent risk, we definitely need to step in and do something for that person to make sure that they're safe. So some of these risk factors, ideation means that they're having thoughts about suicide. Previous attempts, so that could be a suicide attempt, whether it was followed by medical care or not. Knowing someone else who's died by suicide or homicide, which is becoming increasingly more prevalent, not only because rates of suicide are increasing, but also because of social media and how globalization has really changed how we communicate. So if someone has died by suicide, more people will know. Access to method or means. So women and girls tend to attempt suicide more often, whereas boys and men are more successful in dying by suicide because they use a higher lethality means. So what type of means and whether or not someone has access is an important thing to look at. Mental illness is a component. Some mental illnesses such as depression, a bipolar disorder would have higher rates of suicide. Eating disorders actually very high rates of suicide death. And so if mental illness is there, it's added to the suitcase, right? Our really risky ages are that like teen years into early adulthood, 15 to 24. And really sadly, that 15 is actually dropping a bit lower recently, as low as 13. And then 50 plus. In our elder population, it's usually Caucasian males who have the highest rates of suicide. Physical illness is a complicating factor, especially with chronic pain, but it could also be things such as MS or degenerative diseases like dementia that are isolating, which goes us right into isolation. Anytime we're isolated from support systems, from people in general, because humans are communally focused, isolation can be really challenging. Hopelessness is something we always watch for, because then why we're choosing to live often has something related to hope involved in it. And so when that goes away, that can put someone at higher risk. Lack of social support, certainly. And then stigma. Anytime there's stigma associated with mental health, with what population someone's involved, if they're at LGBTQ, there's even more stigma. All of that just adds on top. The thing that we really like are buffers. Buffers are the helpful side of this equation. And buffers aren't taking things out of the suitcase, because all of those risk factors that we have as people will always remain in the suitcase. But you can think of buffers like somebody like putting a training wheel under there to help you carry the suitcase a little bit easier, maybe like 7 training wheels, because you could have so many risk factors, but you've created this kind of safety net around yourself with all these training wheels where you can manage day to day and be just fine, right? So things such as positive social support, spirituality, a sense of responsibility. Having children is a huge buffer, right? Because we feel a strong sense of needing to care for them. Having satisfaction with our lives, the ability to reality test, so being connected to reality. If someone is disconnected from reality, which we'll see in psychotic disorders such as schizophrenia, it's a lot more difficult to maintain for them the present focus that things such as life satisfaction and responsibility require. So those other buffers go out the window. Positive coping skills. I talk to clients all the time who have coping skills, but we also need to think about whether they're positive or not. If your coping skill is drinking alcohol, for example, are we doing that in a way that's safe and healthy, or are we addicted to it, right? And so making sure that those coping skills are positive. My favorite example is I have had a client who listened to music and absolutely loved music. And I asked him what kind of music he listened to for coping, and it was like this hard metal rock, like super intense music that really made him more depressed. So we had to back it up and identify what type of music to use for that coping skill specifically to be effective for him. The ability to problem solve in a positive way is going to be super helpful, as well as having a positive therapeutic relationship. That could be with, certainly with a therapist, but also with another mentor or someone. It could be a primary care doctor or a spiritual connection, like with a pastor, someone like that who is supportive and present for the person. All of those are going to be great buffers for us. So let's jump into what we're really looking for is the person who's the outlier. So they have maybe that underlying mental health concern. They have some of those risk factors. There's an acute psychosocial stressor and an inability to cope. Because often folks who have mental illness, so that underlying mental concern, can face an acute psychosocial stressor, let's say like a breakup, and have the ability to cope with it just fine. So they're not necessarily going to need another level of help. What we have to remember is that right now we're facing the combination of folks who have an underlying mental health concern. We are all facing an acute psychosocial stressor with the COVID-19 crisis, and some people have an inability to cope. So how we identify them? I want to give you a really good visual on the next slide about how we can think through our needs and what's going on for the people that we're working with. So Maslow's hierarchy of needs has been around 60 years or so, and really looks at what order we need services in for our understanding. We really start at that bottom of that pyramid, and you don't move into that next part of the pyramid until you've met the level below. So that very bottom level is primary needs: food, water, shelter, warmth. We're going up into that second, which is safety and security, economic stability, a job or an income. Once you get into that third section around belonging, that's where we look at adding in the psychological components: love, social contact. And as we get even farther, it is status, self-esteem, self-actualization, periods of growth. So when we're in a period of growth, those top three that are blue on the left side there, that's where we sit. As a society, we sit in next level thought. We're all in growth mindsets. We are in focusing on what we can do next and better, and really making our lives look how we want them to. Whereas on that right-hand side, when we are in a period of crisis, we are so heavily focused on primary needs and safety and security that we just get into touching on belonging in that psychological component. So we focus on what we need the most given the situation. When we're talking about suicide, that suicide really falls into those psychological components and is impacted really across this whole hierarchy. When someone gets into those top three sections, they're able to think more and may potentially act more on ideation that they may have. When someone's so focused on food, water, shelter, they aren't necessarily going to ask for help or reach out because the focus has shifted. So what that means is that thoughts of suicide aren't going away. They haven't, disappeared or gone someplace. They simply are happening, and we're not talking about them because we have other things that are more important to focus on in that moment. So if you're the client, you're thinking, your normal is to wake up having thoughts of suicide, rather than waking up having thoughts of suicide and going, I should probably call my counselor. You're going, well, I definitely need toilet paper and what's the new crisis thing to buy meat, right? And then after that is sorted, we think through talking to a counselor or someone. So it gives a good perspective on that shift that we've had as a society from sort of growth mindset to crisis mindset. I want to show you two models. So we're going to start with the ecological model on the next slide. And the ecological model is a relational model of suicide risk. And what it does is it centers the individual, which would be our client who's having thoughts of suicide, within the different pieces of their community. And it's really a prevention model. So where we can impact. suicide risk for that individual. When we're starting at the smallest range, right, we're looking at families. And from families, we're looking at groups, which could potentially involve church or a sporting event, like if you play soccer or something, PTA kind of stuff, organizational level, which is going to be schools. If you belong to, there's a gazillion organizations you could belong to, doing volunteer work, maybe a community organization in your neighborhood, and then the largest circle of that being community, which in this case would be Aurora. So what we're finding is in a typical growth society, right, we can impact at all of these different levels. In a crisis period, such as this with COVID-19, we can impact at that family level, and we really have quite a limited impact from there on out. Our community meeting spaces like libraries are closed right now. And libraries can be a place of sanctuary for a lot of folks who have risk or have other crises occurring, because it allows them to be around people without actually engaging with those people. It creates a safe space, and a lot of those safe spaces are not available. So as we look at how we can impact folks and reach folks who are struggling, we have to shift our focus away from those community places that are closed at this time and use our energy in a slightly different way. I'm going to show you one other model before we jump into interventions, which is the interpersonal theory of suicide. It's very fancy sounding, but really the reason I want you to look at this one is it shows us why connectedness is so important. So this model specifically focused on connectedness. So capability, we all understand whether someone can do something to harm themselves, whether they have means, method, as well as intent. Thwarted belongingness is that sense of whether or not we can or do belong within a community. That is the I am alone feeling when it goes poorly. And when we're alone, we feel as though it doesn't matter, right? We lose some of that hope. Perceived burdensomeness when it goes poorly is that I am a burden. Other people have to take care of me. No one wants to take care of me. No one wants to help me. No one is there for me. Even as simple as, calling a friend and they don't answer. Well, I'm too much work, that kind of statement. When all three of those things overlap is where we get our lethal or near lethal suicide attempts, and that very tiny little triangle there in the middle. So in a period where there is physical isolation due to quarantine or safer at home or stay at home order, whatever the order may be, we have to be very careful around the thwarted belongingness, perceived burdensomeness components, because they're going to actually have more weight right now as our community shifts to a different way of engaging together. And there have been good shifts around engaging more in online platforms, doing things like Zoom, but there are folks who don't have phones or access to the internet or a safe place to live, right? So how do we then still fold them into that community and help them feel as though they belong? So let's look at the intervention ladder. And one of the caveats I have for the intervention ladder is it's always going to go low risk, moderate risk, high risk. It's super basic, but everyone has a role in this ladder, and it's important to look at based not only on your position, your work, your role, your job, who you are in a community. I mean, all of the components of who you are, you fit into this ladder somewhere. So, for example, someone who works in suicide prevention directly with clients may be able to intervene, like myself, at a high risk, which means I also could intervene at the other levels. If someone, let's say they're an administrative assistant at a doctor's office, they actually still have a role. They may not be trained in mental health, but they also can be present with a person and do some of the sort of low risk interventions. And then the key is knowing where you're at and knowing where your cutoff is when it's beyond your ability, so that you can hand it off to the person who can do that next level of risk. So let's look at some of the low risk interventions that anyone can do. Perfect. So providing support and affirmation. Sounds so easy, right? But it really is being present for the person, listening to the person, making sure they understand that they're not alone. We want to normalize to a point where that person feels heard, but not normalize to the point where we're accepting of them harming themselves. So there's kind of that middle zone where we are hearing that they're in a crisis and we are offering to listen and help them maybe problem solve. And the next one, avoiding and minimizing immediate stressors. Well, let me tell you, I've talked to quite a few people recently who would love to avoid COVID-19. And that just might not be an option. It's so far, it's just all around us, right? All encompassing. But let's minimize watching the news. Let's maybe avoid going to the grocery store during really really high times, like 5 p.m. on a Thursday. That might be a high time. But there are ways still to get around stressors, even though those stressors may not be things that we can remove entirely from our environment. The next one, improving and expanding coping to immediate stressors. Having a secondary person support this component is so helpful. When you are stuck in a crisis, your ability to think creatively shrinks. It really becomes like tunnel vision, where you have like, this is my coping skill, this is all I know how to do. Pulling in another person allows for that tunnel vision to expand, for creativity to have a place, so that we can think of other coping skills and ways that we can respond to those stressors. That also allows, right, someone else to come in. We're enlisting the help of someone supportive. It could be a friend, a family member. You could be utilizing the support line. Aurora Mental Health has started a support line so that people who need someone else to talk to have that space, right? And doing that without feeling guilty. A lot of times people don't want to reach out for help because there's probably someone else who has a harder time, or I don't want to waste their time, or, I feel bad that they have to listen to me when I'm in such a mess. Whatever the thing is that you're telling yourself in your head, what we know is that those people are there to be supportive for a reason, because we know it's helpful. So encouraging people to be reaching out, acknowledging that they may have some of that guilt, and encouraging them to set aside that guilt while they're reaching out so that they do continue to do so. The last point, advocating to remove stressors or to access support. Like the problem solving piece, when people get tunnel vision, they don't necessarily see the options that are around them. And it could be that, right, we don't necessarily have the ability to say, oh, poof, there's a vaccine for COVID-19, but we do have the ability to support someone in moving to a safe housing situation, which could remove a whole bunch of stress. We do have the option to support someone in accessing therapy support, or participating in a support group, something where they are able to engage and remove alternative stressors. And what that does is it allows our energy level, like let's say we have, there's my hands, to this much energy, and this much of it's COVID and this much of it is everything else. If we remove everything else, well, that expands our energy availability to deal with the things that we don't have control over and that we can't take away. All right, let's jump into sort of some moderate high risk so you know what those are. I'm going to assume that folks watching this are going to be more in that sort of lower risk intervention. But again, you have to know the cutoff. So we're looking at a moderate or high risk intervention. We're really looking at developing a specific safety plan with that person. There are a number of different ways to do safety planning. The biggest is that we involve someone else. So having someone from the support system, making sure the support system person is aware, setting up some ways to check on them, making sure we have accountability built in. We may also do counseling on access to lethal means, which would reduce the overall risk of the person dying by suicide. As I mentioned, one of the risk factors is having access to method and means. we have access to, for example, a firearm, that's going to be a much more dangerous situation than if we have no access to a firearm, right? And for lethality, that's going to be at the top of the list. One of the things that we work on frequently is having some sort of structure in the life of the person we're working with. This is a point that I want to stay on for just a second, because when anyone's in a crisis, structure can be beneficial. Right now, we all are in a crisis, so encouraging structure for everyone is helpful. I was talking to a client last week, and we established that it was probably her days were twice as good if in the morning she got up and took a shower and got dressed. Something so simple that when we weren't working from home or at home, we did automatically. But in this changing environment, we may not be doing automatically. So taking a few minutes to assess what our days look like and making sure that we have that structure still built in, that we're able to create a boundary from our work life or our school life and our home life, even though your work computer may be in, as it is for me, your living room. So the other kind of higher risk components would be connecting someone to further crisis assessment. We'll talk about some referral ideas for that a little bit later, as well as accessing local crisis services. And all of that information also will be included. That's the point where you're really looking at pulling in someone else. Even if you're that person that works with high risk crisis, you're not doing that alone. As a standard, you should make sure that you've pulled someone else in to be supportive of that situation and make sure that we're doing everything we possibly can with and for that person that's in crisis. So let's talk about some super practical skills next. I mean, we're talking like super practical. We're going to listen to people. We're going to be friendly. These are the 3 F's that I like to use, and I always use this cactus because I've named him Frank, and so he now always goes with this whenever I talk about it. But so the 3 F's, friendly, frank, and firm, are really the foundation of our listening skills that we're using. So being friendly, being compassionate, warm, sounding concerned. And if you're not sure if your tone of voice and how you're talking with folks comes across that way, use a friend or a family member, someone who knows you really well, to give you feedback about your tone of voice, kind of how you are if you're being direct, because they know how we speak best. Being frank, so being candid, being really unafraid to ask or talk about risks very plainly. There can be some concern around saying something such as, "Are you having thoughts of suicide?" But by saying, "Are you having thoughts of suicide?" you're really telling that person that it's okay to talk about it. Versus kind of the flip side of that coin, saying something like, "So like, I know you're having a bit of a hard time, but like, is everything okay maybe?" Yeah, that doesn't mean at all the same thing as, "Are you having thoughts of suicide?" right? Those 2 ways of asking if someone's okay are going to get entirely different reactions. Being firm comes in when we have moderate or higher risk. Low risk, we're really going to lean on that person to be the writer of their safety plan and kind of the architect of whatever this plan is that they need in place. Once we move into moderate and high risk, we still want them to be that. We're just going to be more directive. And by being more directive, we're able to get to a place of safety a little bit more quickly. And that ensures then that we can move into how to treat that person ongoing to reduce the overall risk. So listening skills, I'm sure you all know all the listening skills. That is how we reach people. Right now, we are going to be listening, reaching out. So building trust, demonstrating concern, really using a transition from those nonverbal cues. Unless you're on Zoom, of course, still use nonverbals. But if we're moving to phone, if we're moving to written, those kinds of things, transitioning those nonverbal cues so that the person understands that we're listening and that we're concerned. So every role really will have to do some brainstorming about how to reach the people that they're working with. We know from suicide research that something as simple as a postcard can be effective, not only in maintaining connection, but also in reducing overall risk. So the studies that have been done about connectedness come out of Zero Suicide, and they sent at a month post-hospital a postcard to someone saying, hey, we hope you're doing well. Here's how you talk to us. If you need anything, just call us. Little handwritten, hey, hope you're good, mailed it off. Those clients reported that receiving that piece of mail that was directed to them built their sense of community. So we can not only continue to use written post. I've sent a few different rounds of cards to the team that I work with to kind of do that and maintain that connectedness. We can also utilize social media platforms. I know Aurora Mental Health has been much more active on Facebook than they have in the past, and that's been really fantastic to see, not only answering questions, but really just ensuring that if someone's on Facebook, they can get connected through that platform. And there are so many different kind of social media platforms that different agencies and jobs can use to reach people. One of the other things that I was thinking about too is really encouraging the same activities, but thinking about them in a creative way. So when you have someone who's feeling stuck, like, I used to do game night every week with these people and I haven't seen them and I'm feeling so isolated. Okay, so now they've got a bit of tunnel vision. They're thinking, I only know how to do game night one way. Why don't we then help problem solve that with them and maybe open it up and do a Zoom game night and play games over video? There's a lot of games you can play that way. It may not be the same game, but it's still the same connectedness. I had a client last week talk to me about how her group of friends, she's a junior in high school, were really having, like, it was weird not to see each other in person. So they all went to the school parking lot and like parked in a circle, sat on their cars to talk to each other. And she's like, we kind of had to shout a bit because they were pretty far apart, but it met all of the requirements of social distancing and safety while still allowing a bit of that interaction. So our role with someone who's having that difficulty is helping them open up that creativity and open up that ability to problem solve so that they are able to still do things that they find to be meaningful. This can also be their coping skills, right? So many people are taking up new hobbies. It's kind of ridiculous. I have a friend who was like, I'm going to learn to cross stitch. And I was like, my eyes would go cross trying to do that. But also, yes, do a new hobby. Do something you've always wanted to do. Practice something that you love to do. And use social media as a way to connect with other people who are doing the same thing. Awesome. Let's go to resources and kind of in the neighborhood, what kind of things we have. We do have at our disposal a 24/7 crisis hotline it covers the whole state of Colorado. And they also do chat and text, which is really fantastic for folks who don't feel comfortable talking over the phone. Their website is on there, coloradocrisisservices.org, so you can see that's where you go to chat in, and then you text the word talk to 38255, and that'll start you in a text conversation. It's the same clinicians across that whole team. The crisis hotline also has an option to talk to peer support, and peer support can be especially fantastic right now. Peers are folks who have lived experience either with mental health or substance use, and have gone through crisis before. They have a different way of thinking about that creative problem solving because they've lived it. So when you call in, the first thing you hear is that option to go to peer, to talk to a peer, and absolutely can utilize that and share that far and wide. One of the things that I do with clients who are high risk is that we call the crisis line together. It's really important to have someone feel comfortable with an option. We do this with safety planning as well. We're not going to put something on a safety plan that you've never done before. You know, if the coping skill is, I'm going to play guitar, but you've never played guitar, the likelihood of you following through is quite low. So we're going to make sure that people feel comfortable. Calling the crisis line with someone so that they know what it sounds like, so that they know what kind of questions the person's going to ask at the beginning, so that they feel comfortable to do that in the future is highly beneficial. Please just do it on a, maybe during the day or in the morning when they're not quite as busy. But either way, when you call, just saying to them, we are calling to test the line. If you have an emergency and need to go, please just tell us, so that they have that permission as well. And you can kind of walk through what it is like on the phone. There's also in-person support in Aurora. The Aurora Mental Health Walk-in Crisis Services is open 7 days a week. So they're open 8 a.m. to 11 p.m. And the address is there. It's 2206 Victor Street. That is therapeutic support at the walk-in center. If anyone is in crisis, and remember, crisis is self-defined, right? So if someone is feeling like they can't handle life but wouldn't die by suicide, that doesn't mean they're not in crisis. So making sure that we utilize all of these resources is appropriate. Aurora Mental Health is definitely open. We are open. We are accepting new clients. You can call us to get started at any point. We are providing services primarily via telehealth. And as I mentioned earlier in the presentation, Aurora Mental Health has started a support line. You can call the same number, 303-617-2300, to get connected to the support line. And that support line is available from 8 a.m. to 8 p.m. 7 days a week. So you are able to talk to a mental health professional and really process or brainstorm, right? Because we need someone who can think about it a little differently than us. And as always, if there's an emergency, please do not hesitate to call 911 or access a hospital nearest to you. We don't want anyone hesitating if there is an emergency. CRT officers are handy to request. They're specifically trained in mental health needs, and so it can be incredibly beneficial. It's a slightly different way that we talk to someone, right? Or different language that we use and different things we watch for when we have that mental health training that can be beneficial in a crisis period. Awesome. So I just want to next jump into any questions that anyone has. And then I will remind you when this PowerPoint becomes available, we have references as well as some questions to contemplate around your own assumptions and some language ideas that are in the next few slides as well. So ways to talk about suicide, questions to use if you're like, oh gosh, I've never said anything like this before. There are some different options in there just for your benefit. So Rick, sir, do we have any questions?
We do not. Not in the queue at this time. Excuse me, I'm going to stop share for 1 second here if I could, just to double check that. No, I do not see anyone in the queue at this point in time with a question. So I will go ahead and unmute Dee Dee Poole, who is with the Aurora Chamber of Commerce, and see if there's anything that she may like to add at this point in time.
Perfect.
Hi, everybody.
Hello.
Erin, another amazing presentation on behalf of Aurora Mental Health. You guys are just absolutely amazing. I'm glad. So Rick put the contact information over in the chat for you guys, if you don't already see that. If you need to contact Aurora Mental Health, 303-617-2300. This is now, is this the 6th week, Rick, that you guys have done this for us?
Yes, it is.
I've lost track. And for next week, we have 2 more weeks with Aurora Mental Health presenting. Next week, they are going to be presenting on domestic violence and COVID-19. As I'm sure you've seen in the news that the domestic violence rate is increasing as well. So this is all, you know, for everybody's benefit, to try to get a hold of things before they can become a problem and bring awareness to the community, because quite honestly, this is affecting all of us in many different ways, and some more severe than others. So your mental stability is what's going to help you come out even better at the end, you know, depending on how we go into it and how we receive things is going to depend on how we are able to cope with things. So that's why it's very important for us to be able to make sure that our members are aware of other issues that we need to take care of besides the financial aspect of it. So your mental health and awareness is very important to us. So Erin, you did a fabulous job. The resources are amazing that you provided. If anybody, now Rick, that number that you posted, that's a number that they can call as well if they just need to speak to somebody or have an emergency as well?
Yes, that's the main number, 303-617-2300, and there is a live person 8 a.m. to 8 p.m. on our support line piece of that as well. I
And
do
then
have
after 8 p.m.
a question that just came in, if I could pose that real quick.
Okay.
Let's see. What should you do if you have a friend or family member who may not be honest with you, but you know they are suicidal and not ready to seek professional help?
The biggest thing is to be present regardless. So one of the things that we know about connectedness is that someone might have, because of stigma or fear, or maybe how they've been treated in the past, they're not ready to say anything about what's going on. But if they know that you're there, when they're ready, they will. So if you have that friend or family member you're concerned about, that you're still checking in with them and you're still either, writing them, emailing them, texting them, whatever. We don't want to act, overly stalkerish, but be present with them as much as possible. You can also outreach the people that know them. Let's say if it's a friend, maybe checking in with someone else who's a friend, like, hey, have you been talking to so-and-so? Kind of making sure that that support system is in place around that person, as well as, hey, here's some resources when you're ready. Here's some things if you're ready, like we are here. And what that does is it creates what we build around someone who's at risk anyway, that support network and that sort of safety net, so that when they are ready, it's present for them.
Excellent. Thank you for that. And Erin, I have a couple of shout outs to you saying great job, another job well done.
Oh, thank you.
So I wanted you to hear that from us.
Yeah, it was my pleasure. I like talking about this stuff. I know it's weird, but I do.
And Lori Banks said option 2 for support line to speak to a mental health professional. Okay.
Yep. So when you call in on 2300, it has all of our options for how you get connected across Aurora Mental Health. One is for Spanish, and then 2, the very first one after that is for our support line. And if you want to get connected to ongoing services, you can select the option for Connect to Care, which is our access clinic. We can get you connected for ongoing.
Wonderful.
Excellent.
And they'll send me this recording again, so please
Absolutely.
feel free to forward this on to your friends and family as well. We want them to know they don't have to be a member of the Chamber of Commerce to benefit from this. Mm-hmm. This is for our community. I mean, somebody could possibly, get assistance from this in another state, and it just may, pique an interest to actually go and get some help that they may need, but afraid to do so.
Absolutely.
Yeah, and a lot of states have crisis services set up similar to Colorado, and there is a national suicide hotline. So it's called Lifeline. So if at any point, if someone's out of the state of Colorado and just Google's Lifeline suicide hotline, the number for their area will be listed.
Great.
Perfect.
Thank you so much, Erin. And again, we so value our appreciation and our partnership with the Aurora Chamber of Commerce. So thank you, Dee Dee, again for this opportunity. And I wish everyone a very happy weekend.
Thank you, Rick. And thank you again, Erin. You guys have a great weekend.
Bye-bye.
You too. Thank you.
Thank you, Erin.
Okay, take care.
Mm-hmm. Bye-bye.
Bye-bye.